Welcome back. Well, today we're going to talk about prolapse. I know I mentioned we'd be talking about PfilAtes or the Vesi Lab, and we will be soon, but I want to get this other, in our case, third major pelvic floor disorder described before we go into some of the therapeutic things that can be done to address these problems further. So we're going to talk about prolapse. Now this is a lot more difficult than talking about stress incontinence or overactive bladder. It's a lot more difficult because it's a geometric problem. It's a three-dimensional anatomic abnormality that is unfortunately treated surgically hundreds of thousands of times a year, and most of these, I believe, could have been prevented if patients understood that prolapse, like stress incontinence and overactive bladder, is indeed a fitness issue. And I think maybe you'll need some convincing of that. I think most physicians probably would need some convincing of that. I brought my pelvic model with me. I travel with this all the time when I teach. And let me tell you, going through airport security with this raises some eyebrows. Everybody wants to look inside your bag after it goes through the x-ray machine and see, why are you carrying a pelvis? And they have questions about it. But you got to have it if you're going to try and explain a three-dimensional anatomic problem. And so the pelvic bones and the muscles that are attached to those bones are an essential consideration if you're going to understand why prolapse is a fitness issue. These muscles here in particular are the muscles that keep the vaginal opening shut when a woman's at rest, when a woman's not at rest. These muscles contract reflexively every time you cough or sneeze, laugh, run, jump on a trampoline, kickbox, whatever. I have a ton of patients that are kickboxers. And you know what? They got to be super continent. These muscles have to work really, really well. And if they get weak, if you haven't been paying attention to training these muscles, then symptoms can develop like stress incontinence, like overactive bladder, and indeed pelvic organ prolapse. What's the number one threat to these muscles? We've talked about it already, vaginal childbirth, right? You can imagine if you're going to place an infant's head inside the vagina, these muscles are going to be distended. Damage is going to occur to the muscle directly. Damage is going to occur to the nerves that go to those muscles. And without nerve supply, what happens? Muscles atrophy, right? The individual muscle cells get smaller and weaker, and this opening enlarges. And even if it still contracts reflexively with increases in abdominal pressure, like when you sneeze or laugh or cough, the contraction may not be sufficient to keep this opening narrow. And that narrowing is what protects the connective tissue that supports the vagina. So, better to prevent prolapse than to try and treat it. Mild to moderate prolapse can be managed with exercise. But if prolapse gets much beyond that, it really does become a surgical problem. And although surgeries are often successful, there are a lot of failures as well. 1 in 3 women that have surgery for pelvic organ prolapse end up having another surgery. And what that tells you is that a lot more than 1/3 of women are developing recurrent prolapse, just some of them decided not to have another operation. So again, this makes the point. Better to prevent this problem. Now, I've mocked up a little bit of a model, and I don't know how this is going to play, if this is going to make any sense, but I wanted to do something that would try and convey the three-dimensionality of this prolapse process. Okay, so let's give it a try. I'll be right back with the model. All right, let's take a little anatomy tour. So we're going to start up here with the pubic bone. So this is the pubic bone on the left, the pubic bone on the right, and they meet in the middle. And this is a special kind of joint called a symphyseal joint. It's not like your knees or your elbows. It doesn't have a large range of motion. It does have a small range of motion. And if it separates during vaginal childbirth, it is a very painful long recovery. Fortunately, that's just super rare. The pubic bone comes down here and meets with a bone called the ischium, and this is called the ischial tuberosity here, and there's one on the other side here. The Pilates instructors, I think, have a better name for it. They call it the sits bone, and that really kind of describes what it does. It's easy to understand because this is the weight-bearing portion of the pelvis when you're in a seated position. So the ischium comes up here. The acetabulum of the hip is here. Might know it as the hip socket, where the femur inserts and attaches to the pelvic bone, and then the ilium is up here. So what about the muscles? Well, we're not going to get too concerned with all of the muscles of the pelvic floor. There's 3 of them, but the one we really want to talk about today is the pubococcygeus. So the pubococcygeus arises on the inside of the pubic bone, just behind this structure here, extends along the urethra beside the vagina, kind of loops around the upper portion of the anal canal, lower portion of the rectum, and then back up the other side and attaches to the opposite pubic bone. And that's the muscle you're contracting when you're doing a Kegel exercises. That's the muscle you're training when you're doing the Pilates program. And it's super important because when this muscle contracts, it narrows this opening. It kind of blocks off this opening and protects the connective tissue around the vagina, around the bladder, around the uterus, around the rectum, and keeps it from detaching from the points where it attaches to the pelvis itself. And that's how prolapse is prevented. Let's take a look at the inside real quick. While we're here, you can look at the same thing just from the opposite side. And so again, what we're looking at is the pubic bone here, and the pubococcygeus arising from the pubic bone, descending along the vagina and urethra, around the upper portion of the anal canal, lower portion of the rectum, back up to the other side. Now, from the pubic bone all the way to this pointy structure down here called the ischial spine. I'll show it to you real quick this way. You see this pointy structure here? That's called the ischial spine. From the pubic bone to the ischial spine is a tendon. It's like a clothesline sort of, and it extends from here to here. When you're doing a pelvic exam, you can feel this tendon. It's really pretty sturdy. And there's of course one on the other side from the pubic bone all the way to the ischial spine. And that's the point of attachment for the connective tissue that supports the upper wall of the vagina, the back wall of the vagina. And when this point of attachment is damaged, you can imagine if it were sort of like a zipper, if it started to become detached here, and then unzipped all the way down, it would allow the vagina, which was being held up nice and high in the pelvis, to descend towards the pelvic opening. All right, so I've created a little model for you here. Hopefully this is going to make sense. Not entirely sure. So I have this small sock, as you can see, and there's a string attached to the tip of the sock. And what I'm going to do is turn this like this, okay? And we're going to attach this to the inside of the pelvis, and I'm going to show you how prolapse occurs. Now, what you're going to see is an evolution that in normal circumstances takes many, many months or years to develop, but hopefully it's going to create an effective image in your mind that's going to actually help you understand what prolapse is and how it develops. All right, stay with me now. The sock now is attached to the pelvis, right? The sock represents our mock vagina, and you can see it's resting inside the pelvis. And if we're going to try and make this as representative as possible, it'd be kind of symmetrically placed and attached then to, remember, this clothesline on the right, this clothesline on the left. And what we're going to do is place a little bit of traction on this string, right? Remember, this string is attached to the very top of the vagina. And traction on this string, for our purposes, represents years of abdominal pressure in the context of a weak pelvic floor, possibly the effects of gravity over time, such that the vagina is becoming detached from those lateral attachments I was showing you earlier. Right? And so if we put a little bit of traction on this string, we can pull the top of the vagina down 2 or 3 centimeters, and this patient would have prolapse, but it would still be asymptomatic. She likely wouldn't know she has it. But if conditions were such that this amount of prolapse can occur, it stands to reason that with further time, more prolapse can occur. So if we apply a little bit more traction, we can bring the prolapse right up to the vaginal opening here. And at this point, patients are becoming symptomatic. They're aware of a fullness in the vagina, a heaviness or falling out feeling. And they might see their doctor, they might ignore it. With more time, that prolapse actually emerges from the vaginal opening, creating a bulge. And this brings patients in. This at some point becomes more than can be dealt with using exercise alone. Further prolapse develops as time goes on, until finally you're left with a prolapsed mass that would essentially be unbearable, right? And so it's a little bit of a tricky geometric problem, but this is the top wall of the vagina. This would be the back wall of the vagina. And to repair this, you would have to invert this structure, placing it back inside the pelvis. And attach it to some strong ligaments inside the pelvis that would support the vagina in a way that approximates how the vagina was supported before. But if you do that and you don't train the muscles that permitted the prolapse to occur in the first place, you shouldn't be surprised if the prolapse comes back again. Well, what do you think? Was that helpful or just way too weird? Let me know in the comments below. All right, next week we'll talk about Pilates in greater detail. We're going to talk about the research we did back in 2008, 2009 that led to the development of this program. And we're going to talk about how to actually implement the program safely and effectively. So you definitely want to subscribe to this channel. I sure do appreciate everybody that's subscribed already. Thank you so much. And for those people that are sharing this video, thank you. Thank you for doing that. It means a lot. And if you'd leave comments below, let me know what you think. Let me know what you want to hear about. It'll help me do a better job for you. I'll see you guys next week. Bye-bye.